Okay. Hello and welcome again to Cornerstone Advanced Training with the topics which we have started talking about the use of best tools offered from American Heart Association, managing the pediatric medical emergencies. I'm talking about systematic approach. In a previous video, we have covered the initial assessments as the first level of assessments in pediatric emergencies, and we reached to the point if the child passed initial assessments or if we have completed the initial assessment and the intervention which is related to the initial assessments, so we have to move forward and proceed with the primary assessment. What's the primary assessment? So as usual, first we have to know what is your objective of doing a primary assessment. The objective of primary assessment, which I have to reach to that objective by end of primary assessments, is to be able to identify which system is causing problem for the patient. One of the three major systems: respiratory system, cardiovascular system, or nervous system, or possibly mix of two systems, or unfortunately it might be three systems, all causing the problem. But major of the children are suffering from one system. The one system will be the primary cause, and it might show the symptoms on the other systems. How do you manage that? So we go through that by following the mnemonic of A, B, C, D, E. A represents airway assessments and management. B represents breathing assessments and management. C represents circulation assessments and management, or cardiovascular assessments and management. And D represents disability or nervous system assessments and management. So again, if you go and look at the whole picture, A and B is representing a respiratory system, C is representing cardiovascular system, and D is representing nervous system or CNS. So when I'm assessing each one of these systems, I have to again remember, reaching to the final diagnosis is not my first goal. My primary goal is to identify the problems and resolve the problems one by one. So ideally, finding the diagnosis can be done during the secondary assessments. But during the primary assessments, what can I find? First, which system is causing problem? Second, how severe are the problems? Third, possibly which category of problem it is? And fourth, what are the differential diagnoses on the category which you have been identified? We'll go through it a little bit deeply. When I'm assessing the respiratory systems including airway and breathing. So first I have to identify the airway. I have to identify the problems which is possibly blocking the airways by listening and looking. Listening to the air sounds, looking for the chest rise. If the chest rise is there, what is the sounds? Is there abnormal sounds? If there is an abnormal sound, such as gurgle sounds on breathing or stridor during the inspiratory phase, look like so this means the airway is not fully patent and it needs intervention. What will be the possible intervention for managing the airways? Opening the airway, positioning the airway, if needed, suctioning the airway, if possible, visible, remove the objects from the mouth. If you have done with these 2-3 actions and you find changes on sounds, on chest rise, it's a time to proceed with the breathing assessments. On breathing assessments, what are you observing? We are observing the quality of breathing by four major factors: rate of breathing, effort on breathing, the pulse oximetry measured, and finally about the regularity of the breathing and the effort of the breathing. So by measuring these four factors, you can answer four questions. Is there a respiratory problem? If yes, how severe is the respiratory problems? The respiratory problems might be categorized as a severity under respiratory distress or respiratory failure. So how do you identify between the difference between the respiratory distress or the respiratory failure is related to the four assessments which you did: rate of breathing, work of breathing, sounds on auscultations, and the pulse oximetries. So by analyzing this information, you should be able to say, is your patient in the level of respiratory distress, in the level of respiratory failure, or nothing? If the child is on respiratory distress, what are the possible problems? With the signs and symptoms which you have identified, with the measurement which you have done, you should be able to answer the third questions. So number 3, is there a respiratory problem? Number 2, how severe is the respiratory problem? Number 3, which category of respiratory problem it is? What are the respiratory problems categories? Upper airway obstruction, lower airway obstructions, lung tissue disease, or none of these 3. The fourth one can be disordered control of breathing, means central nervous system, who is responsible about managing the spontaneous breathing in terms of rate and regularity is failed to perform well. So the signs and symptoms of each one of these categories are different, and it can be discussed in a next discussion if it is needed. So in that case, I have done with the assessments of the breathing, airway and breathing, and I identified how severe is the problems, and I am able to determine what intervention is needed. The intervention might be needed after the breathing assessments include providing supplementary oxygens with a different level of different type of devices you use, such as nasal cannula, face mask, non-rebreathing face mask, or possibly using of the CPAP. Or finally, you may decide to go for mechanical ventilation using bag and mask ventilation, or intubate the patients and go for advanced airway management and mechanically ventilate the patient. Whatever you need to do from non-invasive, the most non-invasive, we'll start, and we might reach to the most invasive one, which is advanced airway placement and the ventilation. When you are satisfied with respiratory assessments and the management, it is a time to move to the circulatory assessments. So remember, we should not spend much time on assessing one system. In pediatric emergencies, you don't have much time, and you are still not aware about what is happening to the next system. So this is where a team works help. If you are a team leader and you are trying just to manage a child, you can dedicate your airway manager with guiding the person about what should he do or he does when to reach your objective. Your objective is to provide adequate oxygen saturation for the child, which is between 94% to 98% pulse oximetry, by using a different method and a different technique which has been discussed. If you are happy or at least reassured as the respiratory system problems has been identified and the action has been taken, then you can move to the next system, which is cardiovascular system. Assessing the cardiovascular system to identify the child is in shock or not. How do you do that? The first thing I need to know, we categorize this to two part of assessments. First, check the rate and the rhythm of the patients. If the patient is connected to the cardiac monitor, it is good. If not, I can check the pulse of the child. And because I'm sure the child has pulse, he has already passed initial assessment and he has pulse, I'm not worried to check initially the central pulse. I go to the peripheral pulse of the child and at the same time check the pulse in terms of rate and the regularity and the quality of the pulse. So it is good at the same time to see the rhythm and identify, is this rhythm sinus rhythm or non-sinus, possibly tachyarrhythmia or arrhythmias, brady or tachyarrhythmia. Rate and rhythm one side, the other side the perfusion of the child. How do you assess the perfusions? By quality of pulse, by checking the temperature of the extremities, hands, legs, comparing with the trunk and see the extremities are cold or warm, by checking the capillary refill, how fast or late is the capillary refill, and we all knew the capillary refill ideally should be between 1 to 2 seconds. 1 to 3 seconds, and if it is longer than 3 seconds, it's considered as a poor perfusion. In addition to that, you may check the color of the child and the mental status. If the color becomes pale or cyanotic and the mental status the third, so it looks the perfusion is poor. So the action is needed. If the signs of shock presents, which we have discussed, being pale in color, weak pulses, cold extremities, prolonged capillary refills, and decreased level of consciousness, the patient will be in shock. Again, we need to identify the severity of the shock. How severe is the shock? Is it reached to the hypotensive shock or still it is compensated shock? At this case, I need to check the blood pressure. So I asked my colleague to check the blood pressure and give me the final component and important components of the cardiovascular assessments. If the blood pressure is either low or high, anyway, if the child has signs of shock, the action is needed. So how and what will be the action on managing a child with shock? So most of the shocks respond to IV fluid administration. So in that regard, I need an IV line. So I have to prepare and set and insert a secure and good IV line, preferably little bit large size of the IV cannula, because you might need to administer high rate of IV fluid. However, based on the 2020 guidelines, we should not start with a large amount of IV fluid administration for the shock patients, even though if it is clear to us as it is safe to administer the fluid for the patient. We can start with 10 ml per kg over 10 to 15 minutes, and then reassess the child, and during these 10 minutes we are going to identify the child has no contraindication for fluid therapy, and then we can proceed with the second dose and third dose with a proper monitoring and be sure the patient has no contraindications. So in results of respiratory and cardiovascular assessment, you may find the child has cardiopulmonary failure, both. So in that case, the possibility of the cardiac arrest is very high, and the early management of respiratory and cardiovascular function, which is a shock and poor perfusion, is important. So if this assessment is, again, in a quick time is done and the management started, I might not be able to identify the type of shock during the primary assessments, because identifying the type of shock during the primary assessment is difficult. I need a further information such as history and physical examinations. So which is being done in secondary assessments. The good things is I'm in a safe side. I started fluid therapy. I have get the IV line, IV access, and probably I'm in a safe side. For a majority of the children are getting benefit of fluid therapy. But again, some of them may not. And some of them may have contraindication of receiving IV fluid. That's why I have to quickly pass the third assessment, which is a disability or nervous system assessment. I will look at the child and try to use a quick way of assessment, which is Avpu assessment. That is recommended by American Heart Association to use Avpu nervous system assessments. So look at the child, see, is he alert or not? If not alert, so is he responding to the voice or not? If he's not responding to the voice, is he responding to the pain or not? And finally, is he unresponsive or not? If he is the third level of consciousness, I have to do the further nervous system assessments, include checking the blood sugar and checking the pupillary response. So, which is another topic which we can discuss about it a little bit later. So now I have assessed three systems: respiratory system, cardiovascular system, and nervous system. A and B covered respiratory system. C covered cardiovascular systems. D covered nervous system. And it's a time to expose the child, E, and see if I can see something which can help me to identify getting closer to my diagnosis. So by exposing the child, you should look for any signs of discoloration, rashes, bruises, edema, or any injury or scars in the skin, especially the genital area. Don't forget, some of the child might be under abuse. So checking the complete assessments of the child during the exposure is very helpful and important, especially those who are having low level of consciousness and those who are unable to talk. So by completing this primary assessment, you should be able to answer the objective of primary assessment. What was the objective of primary assessments? To identify the problems, the source of problems in which system it is. You should be able to say which system has caused the problems. Is it respiratory system, cardiovascular system, or nervous system? How severe it is, which category of problem it is, and possibly what are the differential diagnoses. So in this case, we are narrowing the road. We initially say, so this is not a BLS case. Later we said it is, for example, a respiratory case. Later we said it is an upper airway obstruction case. And now, case of upper airway obstruction possibly have either croup or anaphylactic reaction or foreign body aspiration. So now I can conclude my primary assessment and say, not only I reached to the differential diagnosis of this case, but also on the way reaching to here, whatever problem I have identified has been resolved. The solution was delivered. He was hypoxic, I have delivered supplementary oxygen. He was having secretion in the mouth, we have a spray, suction the mouth and clear the airway. We given proper position to the airway. And now I'm quite confident to move to the next level of assessment, which is a secondary assessment. Secondary assessment will be discussed in the next video in details to tell you how it can help us about confirming the diagnosis which is being already possibly diagnosed during an initial assessment. Again, the last message is for the PALS providers. My goal, your goal, is not to identify the diagnosis in the first minutes of arrival. So we have to settle the patient's problem based on the priorities. That's why we use systematic approach and we go step by step. First, we identify if it's a possibly life support needed case. Secondly, we identify which system and how severe is the system. And now it's the time to go and finalize the diagnosis by collecting the history of the patients and using the physical examination, which will be the topic of next video.